Welcome to the deep dive. We know you want to get across complex topics quickly, really understand the core insights, but without all the noise.
Exactly. No information overload here.
The 2021 European Resuscitation Council guidelines, we're going to zero in on a specific part, cardiac arrest in, well, special circumstances and patient groups.
That's right. The source is the European Resuscitation Council Guidelines 2021, and it really does cover a lot of ground.
Okay, let's dive in then. Our mission today is basically to pull out the key updates, the important recommendations from these guidelines. Think of it as a shortcut to knowing what's new and relevant for these quite specific resuscitation situations.
Yeah, and what's interesting is just how detailed these guidelines get for situations that aren't your standard cardiac arrest scenario. We'll unpack these special circumstances, special patient groups, and pull out the insights that, could really sharpen how we think about emergency response.
So where do we kick off? I mean, looking through it, it covers things like severe allergic reactions, body temperature issues, quite a range.
Let's start with anaphylaxis. That's a good one. The guidelines have a pretty significant recommendation here, especially for those really severe cases, the ones that just aren't responding well, or maybe if you're in a specialist unit.
Okay, what's the recommendation?
They talk about considering an IV adrenaline bolus that's intravenous, about 20 to 50 micrograms. Or maybe even an infusion.
So going beyond the usual IM injection if things are really bad.
Precisely. It gives you more direct, maybe more controllable administration when the circulation is seriously compromised. And they also say maybe think about other vasopressors, too, in those tough spots.
Makes sense. Direct IV access gives you more options. What about patients on beta blockers? I think I saw something specific there.
Yes, good point. That's a really key detail. For patients on beta blockers having an anaphylactic reaction, the guidelines suggest considering IV glucagon.
Glucagon, why is that?
Well, beta blockers can sometimes, blunt the effect of adrenaline. Glucagon works differently. But, and this is critical, if you suspect actual cardiac arrest during anaphylaxis, you switch gears.
Right. Then it's back to standard ALS.
Exactly. Standard advanced life support protocols take over. The cardiac arrest becomes the immediate priority.
Okay, treat the arrest. Got it. Now, let's shift gears completely. Electrolytes. The guidelines seem to put a lot of focus on hyperkalemia hypotassium.
They absolutely do. And the big emphasis with hyperkalemia is getting a diagnosis quickly. Point-of-care testing is great if you have it right there.
But if not?
Then the ECG, the electrocardiogram, is often your fastest tool. It can show those really characteristic changes when potassium is high.
Right. The ECG is always a good window into the heart's electrical state.
Yeah.
So once you've identified hyperkalemia, what's the management strategy? What are the key steps?
They break it down into three main goals. First, protect the heart from the dangerous effects of that high potassium. Second, shift potassium out of the bloodstream and back into the cells. And third, actually get rid of the excess potassium from the body.
Protect, shift, remove. Like a three-pronged attack.
That's a good way to put it. Protect, shift, remove.
And how does that translate into actual treatment? They get pretty specific based on the potassium level, don't they?
They do. For what they call moderate hyperkalemia, that's a potassium between 6.0 and 6.4 millimoles per liter. The main thing is shifting it into the cells, usually with an insulin and glucose infusion.
Insulin and glucose.
Yeah.
How does that work?
You typically give, say, 10 units of short-acting insulin with 25 grams of glucose, IV, over maybe 15 to 30 minutes. Sometimes you follow that with a 10% glucose drip just to stop their blood sugar from dropping too low. It's a bit of a balancing act.
Definitely sounds like it. Okay, and what if the potassium is even higher, like dangerously high?
Right. For severe hyperkalemia, we're talking 6.5 or more, and you're seeing those worrying ECG changes, then the approach gets more aggressive. First step. Get expert help involved early.
Makes sense. What treatments are used then?
You immediately protect the heart with IV calcium chloride. Then you hit the shift part again, insulin glucose, maybe add nebulized salbutamol. And then you focus hard on remove.
How do you remove it?
Medications like sodium, zirconium, cyclosilicate, SEC, or petiromer. And definitely consider dialysis. What's really striking is they even mentioned potentially starting dialysis during CPR if the arrest is refractory.
Dialysis during CPR, that's proactive.
It really is. It shows how serious refractory hyperkalemic arrest is.
And I imagine you need to keep a very close eye on their levels throughout all this.
Absolutely. Constant monitoring of potassium, but also glucose because of the insulin. And critically, you need to figure out why the potassium was high in the first place to stop it happening again.
Right. Treat the cause, not just the number. They also touch on hypokalemia, low potassium, right? Brief.
Yeah, just briefly. Basically saying you need to replace the potassium, obviously, and check for things that might be making it worse, like digoxin toxicity or low magnesium.
Okay. So let's move from potassium to temperature extremes. Hypothermia, really low body temperature.
Yeah.
How do the guidelines tackle cardiac arrest in that situation?
So initially, you stick with the standard ALS rates for compressions and breaths. That part doesn't change at first.
But there's usually a but.
There is. The big but is that hypothermic cardiac arrest can be really resistant to treatment, especially defibrillation and adrenaline. If the core body temp drops below, say, 24 degrees Celsius, those interventions might just not work well.
Like the cold just numbs the body to the usual treatment.
Kind of, yeah. The whole metabolism slows right down. And that leads to another issue. Drugs you give can hang around longer, potentially reaching toxic levels because they aren't being broken down normally.
Okay. So how do you adjust the treatment then?
Well, this is a major change from standard ALS. They recommend withholding adrenaline and shocks until the core temperature gets up to at least 30 degrees Celsius.
Withhold them completely until 30 degrees.
Yes. And once you do reach 30 degrees, you give the drugs, but you double the interval between doses compared to a normal temperature patient. You keep doing that until they're closer to normothermia.
That's a huge difference, driven entirely by the physiology of being that cold. Okay, what about the flip side? Hyperthermia, dangerously high temperature.
Right, hyperthermia. The guidelines describe it as a spectrum, from simple heat syncope, feeling faint, all the way up to life-threatening heat stroke.
And heat stroke is the really bad one.
That's the critical one, defined by core temp over 40 Celsius, plus neurological signs, confusion, seizures, coma. If you see that, the absolute priority is immediate, aggressive cooling.
Get the temperature down fast. How?
Use the quickest method you have available. Active external cooling is preferred, so ice packs in the groin, armpits, neck, cooling blankets, even immersion in cool water if possible. Just get that heat out.
Right, physical cooling. Anything else?
Yeah, alongside the cooling, give IV fluids, isotonic, or maybe even hypertonic because dehydration is common. And think about electrolytes as you lose a lot through sweat. They even mention a target cooling rate for exertional heat stroke.
Like heat stroke from exercise.
Exactly. They say a cooling rate faster than 0.1 degrees Celsius per minute is actually safe and desirable. So cool them fast.
Okay. Now there's also malignant hyperthermia. Sounds similar, but it's different, right? Triggered by anesthesia.
You got it. Malignant hyperthermia, or MH, is a rare reaction to specific anesthetic agents. If that happens, the absolute first step is stop the triggering agent immediately. Give 100% oxygen.
And manage breathing.
Yeah, aim for normal CO2 levels, which might mean hyperventilating them. If cardiac arrest happens during MH, you follow standard ALS, use standard cooling techniques, and defibrillation is still indicated with normal energy levels. And of course, there's a specific antidote, dantrolene, but managing the immediate crisis comes first.
Right. Okay, we've done electrolytes, temperature. What about specific medical events leading to arrest, like pulmonary embolism, PE?
Yes, PE, a blood clot in the lungs. It's a known cause of cardiac arrest and often presents as PEA, pulseless electrical activity. The heart's got electrical rhythm, but no effective pump.
So what do the guidelines say about managing that during arrest or near arrest?
They recommend starting anticoagulation, usually heparin, while you're still diagnosing, unless there's a strong reason not to. Basically, start treating the suspected clot.
Even before you're 100% sure it's a PE?
In many cases, yes, especially if the clinical suspicion is high. And if the patient is crashing fast from a suspected massive PE, they talk about rescue thrombolysis, clot-busting drugs, or even surgical or catheter-based embolectomy, physically removing the clot.
Those sound like big interventions.
They are. And because of that, the guidelines stress that decisions around high-risk PE really need a multidisciplinary team approach. Get specialists involved.
Makes sense. And what about the perhaps most commonly thought of cause? Coronary thrombosis, a heart attack.
Yeah, the guidelines acknowledge that coronary artery disease is super common in out-of-hospital cardiac arrest, especially if the first rhythm is shockable, like VM.
So what's the emphasis there?
A lot of it is about what happens before the arrest. Primary prevention, lifestyle stuff, secondary prevention for people with known heart disease, and, crucially, public access to BLS training and AEDs, plus the role of efficient regional STEMA networks for rapid heart attack treatment.
Prevention, public training, fast treatment systems.
Got it.
Yeah.
Okay, let's shift to another complex area. Toxic agents, poisonings leading to arrest.
Right. This section starts with a really important point. Rescuer safety first. Always. Especially if you don't know what substance is involved.
Good reminder. Any specific safety points?
Yeah, they specifically say avoid mouth-to-mouth if you know it's certain chemicals like cyanide or organophosphates. Just too dangerous for the rescue.
Okay, so safety first. Then what's the treatment approach? It's multifaceted. You need to think about specific antidotes if one exists for the poison involved. You need to think about decontamination, stopping further absorption, and maybe enhanced elimination ways to get the toxin out of the body faster, like dialysis in some cases.
And they give examples of treatments for specific toxins.
They do, like using sodium bicarbonate if the toxin causes certain ECG changes, those quinidine-like effects. And they mention specific antidotes for common overdoses, calcium channel blockers, beta blockers, digoxin. Those have specific reversal agents.
What about decontamination?
Activated charcoal is mentioned for GI decontamination, if
Right.
someone swallowed the poison, but only if their airway is secure. You don't want them aspirating charcoal. And yes, specific antidotes like naloxone for opioids, atropine for organophosphates. Knowing the poison is key.
It really highlights how different poisoning is from other causes of arrest. Okay, the guidelines then get into specific settings. This is fascinating. Let's start with the cath lab.
Right, the catheterization lab. Here, it's all about being prepared. Trained staff, knowing the protocols, using safety checklists before, during, after procedures.
And if an arrest happens during a procedure,
They suggest a modified ALS algorithm. Think early about mechanical CPR devices, maybe even advanced circulatory support like ECPR, especially since you're already in a highly specialized environment. And critically, look immediately for reversible causes linked to the procedure itself bleeding, maybe a vessel suddenly closing off.
makes sense the cause might be right there.
Okay.
What about after cardiac surgery?
Post-cardiac surgery arrest actually has, relatively speaking, better survival rates sometimes.
Why is that?
Because often the cause is something immediately fixable, like VF again, or cardiac tamponade fluid building up around the heart or bleeding. The really key recommendation here is the potential need for an emergency restenotomy.
Reopening the chest.
Exactly. If the arrest isn't responding, they say consider it within 5 minutes, which means you need surgical staff ready to go, basically immediately. That 5-minute window is incredibly short.
Wow. High stakes. Okay, what about a dialysis unit? Patients there often have complex issues.
Yeah, key points there are. Keep the dialysis access available if possible, because you can give drugs through it. Be hypervigilant about hyperkalemia, manage it fast if it occurs, as it's common in these patients. And be cautious about big fluid or electrolyte shifts during dialysis around the time of an arrest.
Makes sense. And surprisingly, perhaps, dentistry. Cardiac arrest in the dental chair.
Yep, they cover it. Causes are often related to the patient's underlying health, maybe a complication from the procedure or an allergic reaction. The big takeaways are all dental staff need annual CPR and AED training.
That's it.
It is, and simple things. Get the patient horizontal, clear anything out of their mouth. They also note that AED availability in dental practices still needs improvement generally.
Good points. Emergencies can happen anywhere. What about transport, like in an airplane?
For in-flight arrest, they mention a couple of things. Maybe consider using a mechanical CPR device before the flight if the patient is high risk. If you have persistent VF, consider a stacked shocks, 3 quick shocks in a row. And importantly, they confirm defibrillation is safe on a plane.
Good to know. Cruise ships. They can be pretty isolated.
Yeah, isolation is the key issue. Use all the medical resources you have on board. Consider telemedicine for expert advice if you're reasonably close to shore. Have ALS gear ready and a clear system to call for help on the ship.
Okay. And sports events. We unfortunately hear about athletes collapsing.
Right. The guidelines really hammer home the need for risk assessment before participation and proper planning at venues. That means trained staff, readily accessible AEDs. The biggest factors for survival are immediate bystander CPR and quick AED use.
Early action is key.
Absolutely. And a simple point, don't exercise if you feel unwell. Listen to your body and medical advice.
Good advice for everyone. What about drowning? That's a specific cause of arrest due to lack of oxygen?
Yeah, with drowning, how long someone was submerged is the biggest predictor of outcome. Start resuscitation as soon as it's safe. AEDs can be used, but often the rhythm isn't shockable initially because it's primarily a respiratory arrest. So high-quality CPR is the absolute priority. ECPR might be an option in some refractory cases, but CPR first.
CPR is king there. Okay, lastly for settings, the really tough one. Mass casualty incidents.
Yeah, MCI scenarios, the guidelines are quite stark here. Standard CPR on everyone who arrests is usually not done.
Why not?
Because it uses up resources, people. Time that might be better spent on saving more people who have a better chance of survival with immediate different interventions. You have to use local triage protocols to decide who gets priority. The focus shifts to preventing arrest in the highest priority victims. It's about doing the most good for the most people in an overwhelming situation.
Grim reality of MCIs. Okay, let's move to the final section. Special patient groups, starting with people with asthma or COPD.
Right. In patients with severe asthma or COPD, cardiac arrest is often due to hypoxia, lack of oxygen, or maybe hypovolemia, or even side effects from their meds like beta agonists. Tension, pneumothorax, or gas trapping are also possibilities.
And the heart rhythm.
Usually non-shockable. Think PEA or a systole. Treatment considerations include IV fluids and standard dose adrenaline, alongside managing the underlying airway and breathing problem aggressively.
Okay, what about patients with neurological diseases?
If the cardiac arrest is caused by a primary brain event, like a major stroke, brain bleed, subarachnoid hemorrhage, or even SUDE and epilepsy, the prognosis is generally worse than if the heart was the primary problem.
So identifying that neurological cause is important.
Very important. Early brain imaging after you get circulation back, ROSC, is key. And they note that subarachnoid hemorrhage specifically can sometimes look like a cardiac problem on the ECG and often presents with a non-shockable rhythm, something to keep in mind.
Definitely. Now, obesity. That presents practical challenges for resuscitation.
Huge challenges. Effective CPR is harder. The guidelines suggest maybe deeper compressions up to 6 centimeters, especially if you have a feedback device. Definitely switch rescuers often to avoid fatigue. Mechanical CPR devices might help maintain consistency, but sometimes the patient's size limits their use. Standard defibrillation approach, but consider higher energy if the first shocks don't work. And definitely anticipate a difficult airway. Maybe use a supraglottic device early. Plus, there are logistical issues with just moving and transporting the patient.
Lots to consider there. And finally, a really critical group, pregnant patients.
Yes, maternal cardiac arrest. Thankfully rare, maybe 1 in 36,000 maternities, but needs a very specific approach. Use obstetric early warning scores to spot deterioration early.
And the key intervention during CPR.
After 20 weeks gestation, manual left lateral uterine displacement. You need to physically push the uterus off the major blood vessels in the abdomen to improve blood return to the mom's heart. It's crucial.
Okay, push the uterus to the left.
What? Prepare early for emergency hysterotomy, delivering the baby surgically. If you don't get ROSC within 4 minutes of collapse, the goal is to have the baby delivered by 5 minutes.
4 minutes to decide, 5 minutes to deliver. That's incredibly fast.
It is. It requires a pre-planned, coordinated team response. Standard defibrillation pads and energies are fine. Consider ECLSE CPR in some centers, and know the common causes: heart disease, clots, bleeding, sepsis, preeclampsia, eclampsia.
Okay, it's really clear from this deep dive just how incredibly detailed and comprehensive these 2021 ERC guidelines are for all these special situations.
Absolutely. We've really just scratched the surface, pulled out some key highlights, but it shows that resuscitation isn't and can't be a one-size-fits-all approach when you get into these specific circumstances or patient groups.
And it really drives home that these guidelines evolve, right? This is the 2021 version. Research continues. Staying current is just so important for anyone involved in emergency care.
Couldn't agree more. Which kind of leads to a final thought for our listeners, doesn't it? Well, thinking about this huge range of specific advice from the cath lab to a cruise ship, from hyperkalemia to pregnancy, how does this detailed guidance change how you think about being prepared for emergencies, whether that's in your job or even just in your personal life?
That's a great takeaway question, maybe prompting people to think about what specific scenarios might be relevant to their world and how these expert recommendations could really shape their response if something critical happens.